Good morning and welcome to all of you to this first day of the pre-Congress of the 24th Congress of International Society of Lymphology. We proposed and realized this day completely dedicated to the consensus document because the society's guidelines are very important today in the time of the evidence-based medicine. The same authorities of sanitary of various countries ask us to give them some all the possible contribution to clarify the proper setting of care for our patients. We can start with this discussion. The discussion is absolutely open for each topic of the day, in the morning and in the afternoon. I would like to thank all of you for your presence, and I wish you a very pleasant stay in Rome and a very good Congress to improve our knowledge about our topics, our field of lymphology. I would like give the word to our President of International Society of Lymphology, Guru Sami Manokaran, just to for a welcome by you.
Good morning to all of you. Dear friends, colleagues, ladies and gentlemen, at the outset, I would like to congratulate Dr. Sandro Meglani for organizing a wonderful congress in the eternal city of Rome. Thank you so much. And as a president of ISL, I welcome you all for this 24th ISL Congress of Lymphology in Rome. I'm really glad that Dr. Sandro Meglani has dedicated one entire day for the consensus of this management of lymphedema. Because as you all know, in 1965, when the International Society of Lymphology was started in Europe, the things are different. And we are in 2013, the things are different. Medicine is developing in an ultrasonic speed, enormous speed. In the last 10 years especially, you might have seen greater changes, greater development in various fields of medicine. In that, lymphology is not an exception. In lymphology also, there are a lot of new ideas, there are a lot of newcomers, there are a lot of research has gone through it. So we need to discuss now and then to update our consensus to treat this unfortunate people. As I said, lymphedema at the lymphology is a field where we have varied speciality in medicine. Lymphology consists of surgeons, physicians, therapists, radiologists, anatomists, physiologists. I think this is the only field or only association where we have taken all the field into our fold and we discuss the problem. For example, if there is an association of cardiologists, only cardiologists from all over the world join together and discuss their problem. But in lymphology, we have pediatric surgeons, we have oncologists, we have radiologists, as I said, we have students, we have researchers. So we have taken everybody into our fold and we are open to get ideas, the newer things from our younger generation, from the development of medical science. As our Congress President said, medicine today is evidence-based medicine. We need to prove what we are saying is correct. We need to have a follow-up. It may be all right when you start a procedure and the result may be good for 1 month, but then is it consistently able to give a greater result, or is it a combination of multi-modality treatment that gives a better result than any single modality? Like that, even investigation. When I was a student, we used to do lymphangiogram, which is a difficult problem, but things have changed. Lymphoscintigram is much easier, much informative. MRI angiogram, MRI lymphangiogram is much informative. So we need to add all these things into the newer consensus of diagnosis, newer consensus of management, of anatomy and physiology. Everywhere new things have come. So I am really glad that he has dedicated one single day for the open forum discussion about consensus of this problem today. And I thank and I take this opportunity to thank all the members and all my friends, colleagues and the executive committee for having elected me as the president for the last 2 years and giving me this opportunity. Now let us start the introduction of this today's morning session with Professor Vitti and Michelini. Huh? Mike?
Yes.
Yeah.
This is the time of Michael
Yeah.
Bernas with a short history of the consensus document of a society.
Okay.
Thank you.
Thank you.
Yeah, sorry. Thank you, Sandro and Mano, for the introduction. I'm just going to go over a few slides on how the consensus document was started and changed, and the philosophy behind the consensus document of the ISL, which is a little different than other documents that have been produced from other organizations more recently. So the document had its origins. We'll talk about evolution, challenge, why, what it is, what it isn't, and why is that good. So I'd just like to start with a quote by Carl Sagan. So I think it gets to the heart of the matter when he says the science is essentially a balance between two contradictory attitudes: an openness to new ideas, which we cannot shut off from our documents, no matter what we do, and the most ruthless skepticism of any current idea. So we have to have both of these fighting at the same time. So the consensus document must not be something that we all agree 100% on. It has to be something that is constantly fighting on and constantly changing so that we can both improve and confirm what we know. So as its origin, Michael and Ethel Foldy, thank you, Dr. Foldy, were the real pushers to the start of the consensus document in the Foldy Clinic. And it went through Charles Whitty as the editor of Lymphology, back and forth with the executive committee at that time, and finally ISL members. And finally, the document was published in 1995, the first version of the document. And then each International Congress, as today, we've been arguing about the document. At first, we talked about compression versus MLD and some of the pharmaceuticals that were useful. And then we also talked about it at the interim meetings. We talked more about words. We started arguing about, in microsurgery, do we have to say derivative? Do we not have to say? And all the conflicts among nationalities about which words we choose and how we choose them, and also future treatment options. And the journal has published many articles about the consensus document. There are some really forceful comments that were written in 2004 about the document, 1998, that everybody should take to heart about why they believe this is right or why they believe this is wrong. It's very good to have this, and we are always more than happy to put those comments in the journal so all our members can see, what they have, the opinions of the documents. So the 2013, this is our most recent version, and it's the centerpiece. It's the current views and the diagnosis and treatment of peripheral lymphedema. We know there's a lot of other complications with lymphedema, but it's really peripheral lymphedema. Oops, sorry about that. So it's been extensively cited and used throughout the world, and it's very broad in scope, as our members are in the world. We don't have specialists that do one particular type of the same treatment around the whole world. We have many different centers with many different expertise and many different ways of looking at how the best method is to treat lymphedema. So we need to be sure that we encompass all those, and we don't want to be a formula that says this is how you treat a patient that comes in the door. We want it to be encompassing enough that says if you go into the clinic in Italy and you may want microsurgery, that you can follow the protocol or follow the guidelines of the consensus document and get microsurgery. If you go to the Foley Clinic, you can follow the guidelines and CPT can be administered. We want it to be broad enough to give backing to the important things and yet flexible enough that you can have individual treatments. So because we have all diversity in our society, we have to make the document this way. There are so many different members that have very specific requirements that we must be respectful. So why is the document this way? It's meant to be a guide for generalists encountering lymphedema the first time or people who want to learn about the field. So if a patient comes to the GP and says, I have lymphedema, they could look at our document and they could say, these are the characteristics of lymphedema, these are the possible treatments of lymphedema, these are the possible outcomes, these are things that may be important to consider with the patient or not. It's not a particular protocol that says, you do this first, you do this, you do this, and you do this, and that's the way it is. Because that really inhibits further advancements in the field of people allowing them to modify things for their particular patient. So I think I basically covered that, but these things should be, at the end, they're debatable. And because we want it very broad, we don't have the specificities that we can find in other recent documents. The IUP just published their document, and it has 20 pages of references. That document, to me, becomes very big and unwieldy, whereas our document is getting a little bit long itself in its 10 or 12 pages. We want to maintain something simpler, but yet broad in coverage. And many of these things now we can, with the advent of the internet, we can look up all these specificities quickly and easily and get the references. So we try to avoid having 20 pages of reference at the end of our document. And these are just a few slides. What happens, this is a meta-analysis of meta-analysis, basically, and they looked at big studies with 2,000 patients, over 100 systematic studies of 2,000 patients. And within 4 or 5 years, 50% of the data is already wrong. So we need to have something that is changeable quickly and adaptable, rather than saying this is going to be the set protocol and we're done. So is the consensus document perfect? I hope everybody here says no. And that's what we really want everybody to say. We want to say, is it inclusive? Yes, it tries to be inclusive. We're trying to put imaging in there. We're trying to put physical exam. We're speaking more about genetics, the psychosocial aspects. It has a research agenda in there where we're looking for the future, saying we need these studies. They're not in the field of lymphedema, peripheral lymphedema treatment. There really aren't any documents or any studies that are so well done, randomized, controlled, with very specific groups of patients versus others, that we can say anything of value. We have a lot of good studies, but we don't have great studies. So we need to have the ability to change the future of our field with these research agendas. So final words. It retains its life and individuality while we debate the contents in it. It's always expanding and changing. It's not an algorithm to treat patients, but it's a consensus of what the field is at this point by the experts. And it includes validated treatments as best as we can by published studies, but it pushes for other treatments and it talks about it. Even in the general considerations on the first page, many people are frustrated, and we do say that right in the document, that we use words like may, could, likely, have potential to expand. We don't say this is the way to do the treatment. We just say there are some other things. And there's people that say, okay, we need to have that included, and other people say no. So that's why we're having a big discussion to have the consensus of the group. So from my point of view, let's get started, and hope we have a lot of discussion today on all these different points. Do you want to start?
No, I just want, if anybody wants to give any suggestion in what Dr. Mike has spoken just now.
We should underline that it is evidence-based, the words that you said before. If we can say in some way that this consensus is based on papers published, and so to say something or to write something about the consensus, that it is evidence-based. If we do not want to put there 20 pages of references, anyhow, if you can say that in some place of the consensus that it is based on evidence-based medicine. For that, we can find in the literature, that we know that in lymphology, in some fields, it's not so evidence-based, but it is what we have. So.
Okay.
There's actually a bit of an onslaught on evidence-based, because in some senses it's an illusion. Presumably, and I think it's reasonable to presume that we act on many types of evidence. Some of it isn't in references, some of it's in personal experience, some of it will never go into studies, and some randomized controlled trials, by the time they're completed, are far out of date and totally irrelevant. So there's it's not levels of evidence, it's different types of evidence. And I think we can make the statement, but it's pretty much of a platitude. I think as scientists and as physicians, we act on a variety of types of evidence, and the fact that meta-analyses call it type B, type Q, type 13, I think it's really an illusion, because there's a lot more ignorance. We didn't suddenly enter an era of evidence when it wasn't here 10 years ago. I think that we've acted on evidence, and evidence will improve. And there's actually been some attacks from very high-level epidemiologists about the illusion of evidence and how we have very little that we do in medicine that is truly rigorously evidence-based. So I just bring that up as to be a devil's disciple on that point.
Yes, Dr. Lee.
As an outsider of this ISL, kind of dare to stand up to share our difficulty we went through the year to organize the consensus for the primary lymphedema for the phlebologist group. Indeed, like other IUP consensus, we try to stick to the rule of ACCP recommendation guideline for evidence-based medicine. But turn out, this particular consensus for primary lymphedema, we encountered the exactly same problem as Molly just pointed out. So, the update of consensus 2013, we just submitted to Etiology, presented to a phlebotomy meeting. But one suggestion is we attempted to modify the ACCP guideline fit to the status of primary lymphedema as a part of lymphatic malformation to this particular chronic lymphedema. You will wind up to have a more difficulty than narrower section of a primary lymphedema we had. So I agree with Malik, and also evidence-based. Without that, you cannot quote it any longer, but still there's a room to manipulate, to adjust to the right condition for chronic lymphedema. That's my suggestion. Thank you.
Thank you, Dr. Lee. Dr. Pepindik, would you like to no comments? Yeah. Yes, Dr. Vitti.
I want to make another philosophical point.
Marlies, use the microphone.
I want to make another philosophical point before we start. And maybe the word that's currently being bandied around is personalized medicine. And maybe, in a sense, that's better, because it means you're taking all of the evidence, you're putting it in whatever brains that you have, and any computers that you have, and then you're looking at a patient, and you're saying, what about all this complex evidence in this heterogeneous environment, in this particular patient, at this particular moment in time, in this particular country, in the tropics or whatever? Here is what I would take from the ISL consensus, and this is what I will do now. This is a wise decision for me. And maybe the concept of personalization is, in a way, one that's going to last longer than claiming that you have evidence. Because you can take a look at any of the documents, and they're all dated, and they all have wrong things in them. For instance, in the phlebology document, it states that you make 4 to 5 liters of lymph a day. You don't. You make 1 to 2 liters. So there's an error in there. So when you start getting down to all the data and the statistics and getting very, very specific, you run the risk of being actually erroneous and misleading. So I think the idea of personalizing, of wisdom, of collective agreement, of many, many experts from different fields who see these patients, I think that Mike made those points, and I think that that's in a way the way forward.
Professor Pizzas, yeah.
Thank you. Dear President and Michael, first, for the history of this ISL consensus document, I think that this idea started in 1994 at Itersarten in a ISL Executive Committee workshop meeting. It was the starting. And then after, the first stones for the edification of this ISL consensus document were built in Sao Paulo in 1995. It's the starting of the ISL consensus document, the real starting. First one. Second, of course, I agree with all the philosophical basis of reasonment, but personally, I would be happy if we were able to put in the program of the ISL consensus document a chapter concerning, of course, it's an obsession, but it's important, a chapter concerning prevention. That is, for surgeon colleagues, for radiotherapists, to try to, among a treatment of cancer or anything else, to avoid detrimental attitudes and to avoid the apparition of secondary lymphedema. I think it's important because that goes to the concept of sentinel lymph node, that goes on the concept of our Italian friends of Genoa concerning lymphoscintigraphy and surgical reconstruction attitudes and so on. So I think the next 2 years in San Francisco, we have to add a chapter concerning prevention.
Thank you, Dr. Pizzas, for your opinion. Professor Foldy.
Yes, Yes, another aspect that we have to add to the consensus document is the long-term follow-up. Because, especially in primary lymphedema, what's mean treatment? 5 weeks, 2 years, order that I was able to follow 30 years and so on. It's very important the long time therapeutic results, and then the connection, of course, between right diagnostic measure and the right therapy, because lymphedema is a chronic disease. How the patient manage the life, the job, the family, and so on, it's very important. Thank you.
Thank you, Madam. May I ask one question, Dr. Mike?
Oh,
Yeah. What is our stand on sentinel node biopsy? What is our stand in sentinel node biopsy?
well, I think in the document it would only address it as,
Yeah.
as
It's not been
a
addressed, so I'm
possibility
just asking.
to reduce the incidence of lymphedema. I think Alexander has a good point. We
Yeah.
really don't have a subsection
Exactly.
that says prevention.
Yes.
And we could add that section
yes,
of prevention
yes.
and
Yeah.
add things like sentinel node. We do have it in pieces, but not a prevention section by itself.
Yeah. So I request you in the prevention thing to mention about sentinel node, because that is very much is talked about the field. And people in the aspect of prevention, if a sentinel node can be done and you don't need to go for a total clearance of the axillary clearance, which can prevent post-mastectomy lymphedema. So that I think we need to look into that and add properly, I think. That's the best
For prevention.
word. Yeah, is anybody else? Yes.
Thank you. I appreciate the comments. I would caution us against using the word prevention for the reasons that we've simply seen, even with sentinel node procedures, we're not able to prevent. We reduce the incidence. We maybe reduce the severity. But I would caution us against prevention, and instead would encourage consideration for early identification, which is the construct and the model that I have heard both Dr. Pisas and Dr. Foldy speak to. And I think it gets at an important point that needs to be addressed in the consensus document, and that is the model of care in the delivery system that we use. So when do we initiate the protocol for identifying lymphedema early in patients who we know are at risk from secondary causes? How far out do we follow them with regards to not just intensive treatment and intervention, but the long-term, lifelong duration of the condition? So prospective surveillance is the terminology that we've used in our research protocols in the preoperative and prospective early identification protocol for lymphedema, with secondary lymphedema. So I would encourage us to think along those lines rather than the prevention. It's the monitoring, the methodology for early intervention, and the delivery system model that's used, whether that be hospital-based or community-based, depending on where you are in the world, of course.
Thank you, Nicole. Dr. Okuma.
I quite agree with her. Even secondary lymphedema, it's hereditary determined. We cannot prevent the occurrence of secondary lymphedema. I agree with her.
Thank you. Yes, sir.
Thank you. I agree. Of course, I understand, I hope I understand the goals and the spirit of the consensus document. And I agree with Marlies that we are in the frontiers of our knowledge and in the limits of our ignorance. But I encourage the society and all of us that we need to obtain more and better evidence. We need to respond to give properly answers to good made questions that are okay that we need to understand and we need to respond to the other communities of doctors and patients and politicians and who spend money of others and that all. And we need evidence. We need, if we have methodological issues, we need to resolve it. If we need to re-question or restudy something, we need to do that. But it's not a question of faith. It could not be arbitrary. It needs to be based on evidence. It's maybe issue of another document, maybe a practical clinical guideline or something, not on the consensus document, but we need more and better evidence.
Yeah, I do agree. In the sense the consensus document can be brought out in a broader outlook. But many individual patients has to be taken into consideration when you are treating. As you said, like metabolic disorders has to be corrected and things like that doesn't happen in all the patients. So sometimes, apart from the consensus, we have to have an individual assessment. Some patients need more. So this is on a broader scale. But as you said, we can mention these things in the consensus, that these things we can keep it in mind and do it. Another thing as I wanted to bring it here is, the lymphedema etiology may be different. Whatever may be the etiology of lymphedema, the progress of the lymphedema or the consequences of the lymphedema is basically because of the secondary infection. So even in the prevention aspect, if you can prevent infection, if you can prevent an entry lesion, if you can prevent an injection in an affected limb, so all these things can be brought into the preventive aspect of it, because as I said, whether it is post-mastectomy lymphedema or post-surgical lymphedema or post-infestation lymphedema, the progress of the disease is not basically per se because of the etiology of the disease. It is per se because of the secondary repeated infections. If you get cellulitis one time in any lymphedema, the swelling increases, the fibrosis sets in. So we need to put this secondary infection. Taking care of the secondary infection is very important in all the type of lymphedema, irrespective of the etiology. And like that, the hygiene of the portions. So if there is a poor hygiene in the foot or in the axilla or in the nails, then still you can get lymphangitis in spite of this consensus. So I think we need to add this prevention of secondary infection is very important, irrespective of the etiology of lymphedema. So I think that also need to come in.
Well, I can address that a little bit in the past. I mean, we do say in the first section of the treatment section that pH, low pH lotion, cleansing, those sort of things are basic to everybody. And I think we've had arguments in the past among secondary infection because many patients with primary lymphedema for their whole lifetime don't get any infections, have never had any infections.
That's precisely I'm saying. If you don't get an infection, you can still go on with the same leg. So they don't get increase in the thing. But the basic thing is anywhere, if you get an infection, it is for sure that it is going to increase in size or it is going to complicate the problem. Cellulitis can even cause a skin necrosis. If you have a skin necrosis, if you have an associated what shall I say, fasciitis, necrotizing fasciitis, all these things are common. So when we make a consensus, we should clearly mention about a word instead of putting the ointments and things like that. We can put a word saying that the prevention of secondary infection is very important. As I said, necrotizing fasciitis, once a patient gets, then you have to debride liberally, and when you debride liberally and put a skin grafting or put a resurfacing, then it is not the same type of lymphedema which you are going to handle. Yes, sir.
No, just a moment. Before then, the etiology of lymphedema, we must underline the definition of the illness, because the lymphedema is a disease, not a status as still today we write in our consensus document. The World Health Organization, in the International Classification of Disease, classify the primary lymphedema and the secondary lymphedema with selected codes. 470 for the breast cancer-related lymphedema, 471 for the other lymphedema. These are disease, not status, clinical status. And this is important for the consideration by the sanitary system, as public as private, in various countries, because the sanitary system asks us to discuss, to assist about disease, not about generic clinical status. In my opinion, we must underline better the definition of the illness, of the disease.
Yes, Dr. P says. One minute. Okay.
Sen.
Okay.
Okay, you can go ahead. Yeah.
Carlo.
As some of you knows, my field of work is neonatal intensive care and perinatology. In consensus documents and guidelines of Perinatology Society, Neonatology Society, and Pediatrics Society, there is nothing about lymphatic disease. And there is many problem during pregnancy with newborn severely affects by lymphatic disease, and in the early children with problem linked to lymphatic disease. I think that it could be an occasion to include in consensus document of Lymphology Society just a brief note, but something on this problem. I think that this is not particular, this is not the society exactly for this problem, but the completely lacking of this attention. I think that this occasion may be useful to remember these problems.
Thank you. That's the main idea of having one-day discussion on that. So if you put an input, we are here openly to accept whatever is acceptable for everybody. That is the idea of having today's meeting. Thank you for your contribution.
I know we're prolonging the philosophical issues, but I think at the beginning it's important to lay them down because they will be coming up in every item we discuss today. So I'd like to just in 30 seconds address the point about our now doing very rigorous methodologic studies to provide evidence to convince everybody. And I give you the example of the iron lung in the 1940s. If we were back there, we would be doing a randomized controlled trial on different types of iron lungs. There's a section in the consensus document on research. We think lymphology is moving very rapidly in research, in diagnostic methods, in therapeutic options, and the randomized trial that we would do today might be expensive and irrelevant to just a few years hence. So I caution this worshiping of the randomized control and this very highly tight evidence-based, because it's going to come through all of the discussions.
Dr. Peters.
Concerning infection and prevention of infection, I agree totally with the concept of our President Manokaran. I think the promotion of lymphedema is based on infection accesses. And I remember that many years ago, we felt this concept, but we were not sure. And in 1996, in Tucson, there were two topics on this little workshop meeting of ISL. First one, it was on the malformations, our friend Cristobal Papianik, and the second was infection, and Waldemar Rosalewski explained to us his own scheme of prevention of DLA, the dermatolymphangioadenitis attacks. And from this time, personally, in our team, we make an application that is each patient who had more than one access of infection the year is, of course, proposed to antibioprophylaxis. That is a benzathine penicillin injection one time the 3 weeks or 2 weeks, 1,000,002 or 2,000,004. Of course, it's not very clear. We have not a clear expression of this prevention, of this antibioprophylaxis, but I think it's very important that the promotion of lymphedema is infection.
Thank you. Professor Ulsaski.
Could we put the slide up? Excuse me, in the back? Yeah, could we? This just, well, Professor Olszewski, please go on, but this has the section on antimicrobials already in the consensus document for everybody to look at. Please.
Well, I am listening very carefully to the discussion, and so far as I can gather, according to the agenda, we should discuss first about the profile, the spirit of the consensus, and then go into the details, which we have already discussed. So I would suggest that we, after this, what I say, and some other speakers, why shouldn't we go along the agenda of the day and then discuss in detail all the problems? But first of all, I would like to say that according to my impression, the contemporary consensus is very fine, very okay, but is very descriptive. And we need more concrete data based on evidence-based medicine, of course also on personal experience, but eliminate a lot of uncontrolled and non-repeated by others data which are still contained in this consensus. I showed the text of the last consensus, which I consider to be a good document, but still not very concrete. I showed it to many colleagues from different countries, and they read it and said, what? And asked me, and so what? What do you want to present us? Do you want to present us the present state of knowledge in general, or you want to present us guidelines for diagnosis, treatment, etc.? But the most important, what I heard was, well, you didn't say, this is a document about what? Lymphedema, we don't know what's lymphedema. It should be stated at first. There should be a large chapter on the contemporary knowledge of what is lymphedema, how do we, I mean the pathogenesis and whether this is a disease or is this a symptom. And of course, lymphedema is a symptom of a disease which is not exactly originating from the lymphatic vessels and nodes, but is originating from the tissue. There are various etiologies, etc. This we can discuss, of course, in details when we go along the agenda. But what I would suggest is to make it more general, more concrete than general, because it makes an impression that it was composed by, let's say, people who look theoretically at the problem and not very practically. So some more impact of the clinicians to the document would be very useful. But anyway, it should be more concrete according to me, and first of all, it should start with a description of what do we understand under the term of lymphedema today. Thank you.
I just wanted to pull up. Oops. Here are the general considerations as written in the document. And, you know, as the fundamental starting point, it describes lymphedema. We can look at this a little bit in more detail and see if people have suggestions on how to describe more completely the lymphedema, you know, that as a consensus.
Well, Michael, I can, of course, I know the text, and again, if the, let's say, layman read it, they don't understand anything, because not only because of lack of knowledge of medicine, but even the patient should read it and understand something. So we should define very well what is lymphedema. And the first point is it a disease, a separate entity, or is it a symptom of a disease which affected adversely the lymphatic system? And certainly, the origin of etiology is not primary. I mean, its primary site is not the lymphatic system. In the lymphatic system, this is a secondary, because there is infection in the tissues, so there is inflammation. There is trauma of the tissue, which affects adversely the lymphatics, and then we surgeons make the lymphadenectomy, and of course, in that way, we interrupt the lymphatic pathways, but the first reason for it was a surgical trauma, etc., etc. It might be also, in some cases, filaria, which first of all affects all the whole body, and then is located in the lymphatics, etc. Well, we don't discuss about filaria because this is a very, very, let's say, touchy problem.
Yeah.
But lymphedema is a secondary effect of a disease which is developing in the tissues. What concerns the congenital, let's put it aside, because this is malformation, this is not lymphedema. It looks like edema, but it is not. And of course, what I say may be very challenging and for discussion, but anyway, we have to have a clear, let's say, view on it.
Replay.
This is
just a question. But varicose veins are symptom or a disease? A symptom of venous insufficiency or a disease?
Well, of course, it's the consequence of something. And first of all, it's if, for example, after many pregnancies, this is a consequence of venous hypertension due to the pressure on the iliac veins, insufficiency, dilatation, and incompetence of the valves. In other cases, this is thrombosis, which is affecting the valves, which get destroyed. So if there is the first impact of let's say, something traumatizing the tissue is not in the veins themselves, it's in the tissues. No. Does anybody know what is the etiology of varicose veins? Can anybody say it in a clear way? No, because we still don't know. We consider this is a consequence of something. Much the same is with lymphedema. It's a consequence of a pathological process in the tissues. What concerns veins, the main is, of course, thrombosis. But the next question is, why thrombosis? What is causing thrombosis? Virchow's striate is an old story. It's not tenable in 100% now. Now we know that viruses and bacteria also affect let's say, the endothelial cells of the vein and damage the valves, like in the heart, in the bacterial endocarditis. So the question is still open, and it should be investigated.
But on this way, there is a risk of disagree the International Classification of Disease of World Health Organization, because in this list of International Classification of Disease, as the varicose veins and the primary and secondary lymphedema are considered as disease.
Do I?
Yes, Dr. Pisi. Okay.
Thank you. I mean that as a fundamental starting point, lymphedema is external manifestation of lymphatic system insufficiency. That's not correct, because you can have dynamic insufficiency of the lymphatic system, and if you put that in these terms, every edema is a lymphedema, and we know that that's not correct. So for me, lymphedema is only when the insufficiency is because the loss of transport capacity of the system, and that must be maybe correct. But the problem is, okay, that's a concept, but then, yeah, okay, but it's a little bit deeper.
We cover it, but
yeah, I know, but it's in the first point, it's wrong. The first definition of lymphedema this way is wrong, and then the problem is, okay, we have a concept of what lymphedema is, but when you need to choose between two groups of women in breast cancer treatment lymphedema, you need to take measures of the arms, volumes, and so on, and then lymphedema is completely different defined. So we have a problem on a concept, and then on methodological issues on when we can do that, we can say we have a lymphedema, diagnostic problems, and then what can we offer for the treatment, and how can we evaluate if the treatment is going or not.
Yeah, Dr. Peace.
Yes, I understand this discussion. I think for many years ago we started this discussion, the difference between disease and symptom and sign. I think we are focused on this problem. I understand we are able to discuss on this topic. Nevertheless, I am a little afraid because we are so polarized on this concept. That is a discussion of a sex of angles, and it's the same problem to ask the relationship between the egg and the bird, the origin, the bird and the egg. I think we can discuss, but I don't be convinced that it is the most important question of ISL consensus document.
Thank you. Yeah, Doctor.
Thank you. I think that we can solve the problem in this way. We should consider edema the symptom or the sign, lymphedema the disease, which includes fibrosis, infections, late effects of nodal dissection, congenital malformation. So lymphedema is a disease with its clinical characteristics. The sign is edema, but lymphedema means more than edema. So we can solve the problem in this way, I think.
Here, there is the text.
Dr. Oshevsky, too. Oh, Pierre?
And
Okay.
the text explain.
One comment, because it's a problem of legal definition. In Belgium, we had the reimbursement of secondary lymphedema by the national insurance system for the treatment, physical treatment, and so on. And thereafter, we had primary lymphedema included the listing. And they had a great problem to define what was primary lymphedema. And finally, the solution found in Belgium was to say secondary lymphedema, okay, symptoms, symptomatic. It's clear. Other form of lymphedema, edema of lymphatic origin, we had to prove it was of lymphatic origin. In Belgium, it was chosen to apply lymphocytographic investigation to any patient coming with edema, upper limb and or lower limb, and to apply lymphocytography. And if I fulfill criteria, it's a lymphedema, edema of lymphatic origin, primary or secondary, no problem.
Dr. Oshevsky, then Dr. Foldy.
Well, there are two sides of the coin. One is a legal one, and let's drop it, because the lawyers, they rely upon our opinion and our expertise. And because of that, this is the classification of the diseases as it is for today. But let's look in a sober way on the etiology of lymphedema. Do you know any condition which affects primarily the lymphatics only? If yes, somebody will stand up and tell us about it. There might be some microbes which have specific molecular affinity, or the endothelial cell have to them, and they may cause some kind of lymphangitis, primary lymphangitis. But this is something very rare. And the most common is the process which develops first in the tissue. It may be in the skin, in the subcutaneous tissue, in the bone, in the liver, or in the gut. And then it affects adversely the lymphatics draining this special area. And this might be microbes or viruses, or this might be trauma. This might be removal of the nodes in cancer. But this is the primary factor. The secondary, the response is of the lymphatic system. And then when we have the stage of, let's say, insufficiency of the transport capacity of lymphatics due to the primary cause, then the secondary process is what we call lymphedema, because there is lack of transportation of fluid, etc., to the blood circulation. I understand the process like that. So first of all, there is a symptom only, and then we may call it let's say, a disease which is composed of two, let's say, parts. The first is the primary, the change in the tissues. The secondary is in the lymphatics. So we have to treat both. If we, for example, prophylactically give antibiotics, we, of course, in some way compromise the growth of microbes in the tissues and not in the lymphatics. So I understand the whole process in that way. The primary factor, pathological factor, secondary is the response of the lymphatic system. Now, what concerns the other question of the high output insufficiency of the lymphatic system, I don't understand it. Because if we have cardiac insufficiency or hypoproteinemia and peripheral edema, this is some kind of safety reservoir, because the blood system was overloaded with fluid. And the lymphatics are quite healthy. They have nothing to do with it. And had they transported away suddenly this whole mass of fluid, we would die of pulmonary edema. So we should understand the nature, the physiology first, and the sequence of the events before we define what lymphedema really is. Lymphedema is only a symptom of a primary disease which is caused by insufficiency of the lymphatic system in terms of transportation of fluid and all its constituents.
Baltimore, I have just a couple of comments before Dr. Foldy, but one thing that we explore in the lymphatic system is patients with primary lymphedema or the mouse models where the initial effect is a change in only the lymphatic vessels rather than secondary changes, what we may see in patients. So we have to take into account there too. And I understand your concern, I guess, with the definition of the document. However, if we were able to fully explain everything, we would have a book up here, like we have books for the lymphatic system. So we have to, I think, estimate that the patients or the physicians and the therapists will have a certain minimal knowledge about the lymphatic system, and then they can look at our document and go beyond that. This is not a zero to the end. This is something from the beginning with a little knowledge to put you on the right pathway to get to the end. And I think otherwise we can make our own book, and I think we're always going to have that struggle.
Yes, yes, very shortly. For me, is lymphedema a disease, like Professor Olszewski said, and disease due to changing of the interstitium on the area of the lymphostasis, blood capillaries, the endothelial cells of the blood capillaries, lymph capillaries with endothelial cells, the connective tissue with the cellular component, with the extracellular component, build a functional unit. And in lymphostasis, you saw very early, I can remember, Professor Olszewski, what kind of role the cytokine have in the changes. Then for me, punct 1, the tissue answer for the lymphostasis. Punct 2, the changes of the lymph vessels itself. And third, the changing of the lymph nodes of the area of the lymphostasis. This is the very important thing to define the lymphedema as a disease. Thank you.
Dr. Zuba.
And then
Matassi.
No, yeah, he
After Zuba,
Matassi.
I've only a short comment. We are getting into some kind of academic discussion. I mean, in terms of cause and disease, symptom and disease. Well, this is the problem of all medicine. I mean, look at hypertension. Symptom or disease? We have many causes of hypertension. Many unknown. Look at heart failure. Symptom or disease? There are many causes of heart failure. Coronary heart disease, heart attack, and so on and so on. I could go on. So this is the academic discussion. We have to state what is lymphedema, and then state what could be the causes, because there may be many of them. Thank you.
Yeah, thank you. Dr. Matassi.
So going back to the practical problem, but I think it's important. We have used since a long time to use the term lymphedema, and we, as physicians, we know what it means, and we look at it as a disease. But the problem can be to the health system and to others that they can understand this term of lymphedema as a symptom and not as a disease. So by analogy, if we could call varicose veins, instead of varicose veins, venostasis, that will mean a different thing. We can understand that it's a disease of the veins, but the problem is that we are explaining or describing a symptom. So a solution could be, for example, it's a personal proposal, if we call this lymph drainage disease, or lymph drainage pathology, and then we can add the term lymphedema to point out that it is a disease. It can be a solution. It's not easy, I understand, but why not trying to put on this kind of explanation?
Yeah, in simple terms, for example, a congestive cardiac failure patient develops edema, which can be considered as symptom. The moment you treat the congestive cardiac failure, the edema disappears. Like that, even hyperproteinemia gives edema, and then once you correct the hyperproteinemia, it disappears. When you have anemia, you have edema. When you treat the anemia, it disappears. But as Dr. Foley said, in lymphedema, which goes into a chronic problem from a primary disease as a secondary manifestation, and then subsequently goes many changes, then it has to be considered as a disease and then has to be treated according to that. So that's a better way, I think, of understanding this than keep on fighting on that.
Dr. Seth.
Yes, sir.
Michael, you're defending the contemporary consensus. It's not this. We're talking about the, let's say, pathogenesis of lymphedema, and we're on the same side of the barricades. And now, I again underline that in the so-called lymphedema, I mean clinical term, and in a practical approach, as we have patients every day, we should treat two, let's say, parts of the disease. One is the primary factor, which might be infection, which might be a scar, etc., etc. This is what caused lymphatic insufficiency. And the second is we should treat the effects of lymph tissue fluid stasis in the tissues using different methods. But there are two, let's say, two targets in treatment which we should take into consideration. Not look solely upon the lymphatic system. Look also at the primary factor which damages the lymphatic system.
Could I ask Christine if you might say a word on your view or from your document, how you guys define lymphedema, or how it worked best for you? In Christine, sorry, Carla. Not to put you on the spot.
Thank you, Michael, but you did. In the UK and in the lymphedema framework, we have used the term chronic edema, and we've taken very much a public health perspective. And really, we've done this because we recognize the complexity of patient groups that end up with a chronic edema, and for us that's defined as any patient who's had an edema present for more than 3 months. In our earlier definition, we included things such as not resolving completely overnight, for instance, not resolving with diuretic therapy. And I think there is a real challenge for the perception of people who are not lymphologists about what patient groups are affected. We've just done some recent epidemiology in Derby, and actually the patient groups, if you look at this from a population perspective, so not just people coming through the lymphology door, the actual number of patients with primary lymphedema may be as low as 10%. And the other 90% are a complex range of patients who, for instance, may be related to immobility, they may be a venous disease, they may be a whole range of issues. So that's why we've taken that approach, because we feel we're understating how big this problem is across the world. And we have in places like India, obviously, issues such as filariasis, but even in places like India, there are many patients who have other forms of chronic edema as the underlying issue. So I think that's our take on it.
Thank you.
I think we have finished the general consideration of the lymphatic disease. We'll move on to
maybe one more comment from Carlo?
Yeah, okay.
Just a point. I understand that tomorrow we speak about this problem, but just a note. Many countries, many law, many different approach. In Italy, there is many problem to treat and to have a reimbursement from health service for this type of disease. I think that in the consensus conference here of the ISL could be useful to establish the criteria to include lymphedema disease in general as a rare disease. We have a great problem. When we have a newborn or very young child to treat, we cannot use the term lymphedema, lymphatic disease, or some like this. But we must use Noonan disease, Turner disease, or some other. But there are many, many disorders that are not specifically classified as rare disease, but this disorder have lymphedema as an important part of the complex. So, if we start from the disease to arrive to lymphedema, many patients, I think, have not the possibility to be considered in this group of patients. But if we start from lymphedema in general, and we define what are the criteria to consider this as a rare disease for health system, it's very important. So I think that not in detail, because I think that it's not possible to treat this problem in detail, but general consensus, general guideline to consider this as a rare disease may be really useful. And I don't know what you think about, but in Italy this is a problem. I don't know in USA or in other countries.
Thank you. I think we will move on to the next topic of...
And last consideration, Saskia.
Yes, Saskia. Okay. Yes, please.
The microphone.
In the back. Right there.
The last.
Raise your hand so that she can find you.
Thank you very much. I've listened very carefully for the last hour to the discussion about if lymphedema should be a disease or a symptom. And again, there's disagreements and agreements, but I think the decision has been made because when you look in the dictionary, it clearly states that lymphedema is a disease. So my question is, who really makes the decision in a dictionary that lymphedema is actually a disease? And that's just a question to the audience, because if you look in the dictionary, lymphedema is a disease. So it's open to all of you to respond to that. I'm just curious.
So you want us to go by the dictionary?
Well, it is to the outside world.
Yeah,
you know,
but
when people look in the dictionary, lymphedema is a disease.
Yes,
it's already the decision has been made, but who makes the decision? And is there?
Yes, as Professor Wolswaski said, that's for a common man. But when you are making a scientific consensus, we have to give some explanation why you want to call something a symptom, something as disease. So which forms a symptom, which forms a disease, that's what we've been discussing. By simply opening into a dictionary and say that this is a disease, we don't need this much discussion. So the discussion is mainly meant why it should be called as a disease or why it should be called as a symptom. But as many of the people has accepted it, if it is an edema which disappears, then you call it as a disease. If it is a lymphedema with chronic manifestations, then you call it as a disease because it is still there. It doesn't disappear. Whereas the edema comes and you give medication, it disappears. It's those kind of things comes under symptoms. And lymphedema being a chronic problem, then it has to be classified as disease. Probably that's the reason that they have put in the dictionary that this is a disease. So we'll move on to the next topic because we have time to finish all these things. So if we can keep up our timing also, it's very important. So let me invite people to talk on lymphatic malformations. Dr. Matasi, his opinion, Dr. B.B. Lee, and Dr. Michelini, and Dr. Pependik. Yes, Professor Pependik. Yeah.
Okay.
Answer.
Okay.
If all of them are coming here, then we can go.